Great. Welcome, everyone. It is 1 o'clock on Tuesday, and you're in the House Healthcare Committee. And today we have Ina Backus with us, who is the Director of Healthcare Reform for the Agency of Human Services. And she's going to we've done a lot of introductions last week, I guess I should say. A lot of the agencies have come in. We've talked and probably have heard the term all-payer model. We've scratched the surface of what that is. So Ina is going to help us with the history of where we are today. And then she'll actually be back, I think, tomorrow to talk about the all-payer model negotiations that are currently happening for the next phase. So today is definitely more of a history and to bring us to the point to talk tomorrow. Since a lot of us are new, I want to do introductions again, and then Ina, I'll turn it over to you. Let's start on Zoom. We have a member joining us. So Bobby, do you want to introduce yourself?
Hi, I'm Bobby Farley's Rubio, representing Caledonian One, which is Barnet, Reigate, and Waterford.
And Bobby, if you have any questions, just use your hand function and we'll make sure we call on you. Art, you want to go from here?
Sure. Rep. Art Peterson, live in Clarendon, represent Rutland District 2, Clarendon, Wallingford, West Rutland, and east of Rutland.
Hi, Ina Leslie Goldman, Bellows Falls area, Wyndham 3, Rockingham, Westminster, and Brookline.
Hi, Ina. Daisy Berbecco, I represent Winooski.
Hi, Ina. Rep. Cordes, Lincoln.
Topper McFawn. I represent Barrytown and a small piece of Williamstown.
Lori Houghton, City of Essex Junction.
Hi, Ina. Alyssa Black. I represent Northern Essex.
Brian Sheena, representing Burlington, specifically the part of the Old North End and the East District.
Alan DeMar, representing Montgomery and Enosburg.
My name is Joe Andriano. I live in Orwell and represent Shoreham, Whiting, Sudbury, and Hubbardton as well.
Great. It's all yours, Ina.
Great. Thank you very much. It was nice to meet all of you, and good afternoon on such a splendid sunny day. I am going to talk with you about Vermont's history in healthcare reform, particularly relative to healthcare payment and delivery system reform, of which the all-payer model agreement is one of those initiatives. And as Chair Houghton said, you've been hearing about it some already, and you will be hearing more about it relative to Act 167 and the work we're doing to explore future potential multi-payer agreements that include Medicare as one of those payer partners. Before I dive in, I think there are some other folks that you'll certainly want to talk with more about this topic, particularly the Green Mountain Care Board has a role in the all-payer model. It has a number of roles in the all-payer model, but it does track and report the results of the all-payer model relative to these targets that the state has in its agreement with the federal government, and certainly can provide you more information with respect to those performance targets. And also my colleagues in the Department of Vermont Health Access in the Medicaid program, which has a contract and works in the all-payer model as well. It operates a program that's called the Next Generation ACO model. And this might be another place where you'll want to dig more deeply with those colleagues in terms of what the work has been over the last number of years in the all-payer model agreement, and the information that they can bring to you on the topic of performance and other topics about their experience in operating the program from the DVHA side. So I'll go ahead and share my screen now, if that makes sense.
Yep, that's great. And Ina, do you want questions as we go, or do you want to move through the presentation and do questions at the end?
I love questions as we go. That works well for me.
Okay. And we'll just watch. the time? We have you till 2, correct? Or 2:15 maybe? We have you till 2:15. Are you good with that?
Yep, I'm available until 2:15, yes.
Okay, great.
Yeah. Yes. Okay, so I'll just give you an overview. Actually, let me just, sorry about this, go into, can you all still see my screen clearly?
Yes.
You're seeing presenter mode though, so
Yeah.
you go to display settings, and then you should be able to switch that. There you go, yeah.
Okay, does that work better?
Yes, thank you. Thanks, Joe.
Thank you. Great, so I'll give a little overview of what I'm going to talk with you about today, and certainly if I don't cover some of the topics that you're interested in, I welcome you to raise questions, and I'll do my best to try to answer. But the first component of the presentation is to talk with you some about what is healthcare payment and delivery reform and what problems is it trying to solve, and then to give a high-level timeline of Vermont's healthcare payment and delivery system reform efforts over time, and to talk specifically about Vermont's all-payer accountable care organization model agreement, giving you an overview of that agreement, and then spending some time talking about the implementation improvement plan that the Agency of Human Services published in November of 2020 around the implementation of the model and recommendations for how to improve the state's performance in our all-payer ACO model agreement. So the first piece, what is healthcare payment and delivery system reform and what problem is it trying to solve? So I think it's very important to ground in the problems, since the healthcare system is so large and there are so many aspects of it, which I know that you're working through as a committee in terms of orienting to the insurance marketplace and prescription drug costs, as well as who the players are in the healthcare system, providers across the care continuum, hospitals, primary care, mental health and substance use disorder providers, just really started, I'm sure, gaining lots of appreciation for the breadth of the healthcare system. And with that, in healthcare reform, thinking about various healthcare reform efforts, it's important, I think, to be very clear about the problem that you're working to address. And when we talk about healthcare payment and delivery system reform, we're really talking about payment reform that seeks to address the incentives that are created by a fee-for-service reimbursement model, which is the predominant model for reimbursement in healthcare in our country and in other countries as well. And when we pair payment reform and delivery system reform together, which certainly delivery system reform, looking at how to better and more efficiently deliver high quality health care in the system, that can exist separately from payment reform. But there is a strong hypothesis that the way that the system is paid does drive the system, unfortunately, in a way where care may be less coordinated. The emphasis may be less so on preventive care and primary care, and more emphasis on care that is more high intensity, more complex, and also perhaps services, images, scans, lab work, and so on, that may be redundant or unnecessary. A lot of times people use the terminology that there is waste in the healthcare system, and that waste refers to services or healthcare delivery that is not necessarily needed, but is reimbursed regardless of whether it is improving health outcomes, regardless of whether it is necessarily impacting population health. And in that, waste is unnecessary services and experiences for people, but also a total cost of care for a healthcare system, which is inflated because of that waste. So the fee-for-service reimbursement model is really what we're looking at when we're thinking about healthcare payment reform, and moving away from the fee-for-service payment model also then provides more flexible reimbursement models, or reimbursement models that, in addition to fee-for-service, have a strong link to quality or value and may be important for improving healthcare quality and value in the system. There's a framework that, and this slide represents the framework. This framework has been created by the Learning Action Network that consults to the federal government on payment and delivery system, payment and delivery system reform, and provides a way for us to think about how you can move in payment models from fee-for-service further away towards payment models that may have stronger incentives for improving population health and for moderating costs. So category 1 of this framework is the predominant payment model for healthcare services, which is a fee-for-service model that has no link to quality or value. That means that payment is provided regardless of the quality or value or outcomes associated with the service. And then moving to the next category, the category here, category 2, is fee-for-service with a link to quality and value. And in this category, that means that there are still fee-for-service payments, which are really the predominant method of payment, but that those payments are being linked to care coordination fees, so paying for providers to work with one another to better coordinate care, payments for health information technology or other investments that can improve the experience of care, can improve the quality of care, can lead to improved population health and moderate healthcare cost growth by creating a system which is more efficient and focused on quality. Within this category, there's also a category of providing pay for reporting, where there are bonuses associated with reporting additional data about the performance of the system. And then there's pay for performance payment models, which include bonuses for quality performance. In category 3, moving away from fee-for-service, there are alternative payment models that are built on a fee-for-service architecture, but that have a component of incentives in terms of shared savings for providers. And so what shared savings means in this context and what shared savings models can include upside and downside risk, as reflected here in this chart. And what that really means is that there is a target set for the total cost of care for a population of individuals. Providers work with payers and determine that their providers and the payers will share in that total cost of care responsibility. The target will be set, and if the care is delivered in a way where it comes in less than the target, then that means that there are shared savings, and those shared savings can be between the payer and the provider. There can be arrangements where the provider only shares in savings and isn't at risk for financial risk for performance. In a downside risk arrangement, which is within type B, providers would be at risk for the performance and may owe back to the payer a portion of the dollars for which the target was exceeded. And then finally, category 4, population-based payment. Here in category 4, there are specific population-based payments that are generated for population based on an estimate of per member per month payments, comprehensive population-based payments in category B include global budgets or full percent of premium payments. And then finally, in category C, there are integrated finance and delivery systems, including global budgets for integrated systems. An integrated finance and delivery system might be like a Kaiser system in California, where the payer and the providers are fully integrated as one system.
That's a lot. We have a couple of questions, Ina. So Art?
Yes, thank you. Ina, are all 4 of these categories in operation right now, or are these theoretic, moving from 1 to 2 to 2 to 3, 3 to 4? What are we looking at here in terms of what's happening right now?
That's a really great question, and I've attempted to demonstrate that in the following slide to a degree, but I can say that all 4 are definitely in operation now. Vermont has a considerable amount of payments that are moving away from fee-for-service, more than the goals that CMS has for the Medicaid program. For example, CMS, the Center for Medicare and Medicaid Services, has a goal that Medicaid programs have 50% of their payments in these alternative payment models by 2030. Right now, Vermont Medicaid in 2021 had 68.6% of its payments in these alternative payment models. And our Medicaid program is the most advanced in alternative payment models, and you'll hear the terminology fixed prospective payments. That means that Medicaid is making payments through its agreement with OneCare Vermont that provide for a portion of dollars for those providers that agree to participate. Those dollars are paid in advance and are set. And if the care is more or less than those dollars, then it remains that the dollars are what the providers get. We also have, certainly we have category 3 that's active in terms of payer contracts, and category 2 is where our Blueprint for Health, which is also an all-payer or multi-payer program, is situated. Blueprint for Health is providing for enhanced payments for high-performing primary care practices that are called Blueprint for Health patient-centered medical homes. And it's also providing investments for community health teams. So we have things in all 3 areas. And I think I can just skip ahead to the next slide, which kind of describes our payment models over time and where they fit into those categories. So category 2 is the red box. Category 3 is the, we do have part of the commercial and ACO shared savings programs are in the purple box or category 3. And then our goal is to push more payments into category 4. We do have some payments in category 4 today, but the goal is to push further towards category 4.
And Ina, we have another question, Alyssa.
Just a clarifying question. You said 60-some, I can't remember the percentage, 60-some% of Medicaid are in one of these payment models. So you're referring to category 2, 3, and 4. and I think you're maybe giving us a little bit more information now, but do you have a percentage that is in each one of these different types? Is the 60% combined across all category 2, 3, and 4s?
That's a great question. No, it is not. It's about 69%, and it is specifically, I think that the 69%, I would defer to my colleagues in DIVA about whether or not it's in category 3 and 4 or just in category 4. But certainly it's in those categories 3 and 4.
Not in category 2.
Correct.
Okay, thank you.
And we have another question, Art?
Yeah, kind of to follow up on my question before, Ina. As a consumer, someone go to the doctor, seeing a medical professional, how do I know, is there a way for me to know which of these categories the doctor I see gets reimbursed by? Because it seems to me that would be a determiner of the type of care you get if I follow this. I'm a little skeptical of that even, but as I follow it through, it would seem that would tell me what I need. If the doctor I see is in category 2, then I know she in my case is doing a certain thing. You know what I mean? Do we know this going in, or does the patient know that?
That is a really excellent question, and I think one of the things that we want to have definitely highlighted as being important is for there to be reflected. These are broader reimbursement models that are usually encompassing for these reimbursement models, particularly for like a hospitals accept fixed prospective payments, for example. And then those hospitals have arrangements with the providers that they employ, and those arrangements may differ from the broad payment model that the hospital has contracted with in this case, an accountable care organization for, or it could be a contract with a particular payer that the hospital contracts with. So, there are multiple layers of contracting that are happening, and I think that certainly we would want to see as much alignment as possible in how a larger provider entity is making sure that the incentives are aligned across its organization, but precisely how those providers work with those entities work with the providers they employ is a question that I don't know that all providers would know whether their particular arrangement aligned with these broader payment contracts.
Great, thanks, Ina. We have one more question, then we'll move on. Joe?
Yeah, this is some pretty complicated stuff. I'm trying to wrap my head around it, and perhaps this is something that will just become clearer later in the presentation, so feel free to have that be your answer. But I guess, and this is sort of related to Art's point, I'm trying to think about this from the perspective of a consumer, and perspective of a consumer as I am with a chronic health condition. And I recently went through a situation when I was trying to get a very expensive medication, and my doctor's office had to fight with my insurance company to get the approval for that. Now, I can see sort of in a category 1 fee-for-service approach how there's a benefit to the doctor, and you could make an argument either way. You could say, well, the doctor just wants to do it because they're going to make more money that way, or you could say from the patient's perspective that aligns the doctor more with me because, they're arguing for this particular service. But as I start looking at some of these other categories that you're giving that bring up the idea of shared downside risk with the provider, that makes me worried as a consumer of healthcare, because if my provider is going to get dinged for, arguing for the type of care that I need because it's not in alignment with some population-based payment model that we came up with, how does that affect the consumer of the healthcare, making sure that they get the care that is appropriate to them, that will have the best clinical outcomes, when we're talking about things like shared downside risk and things like that between providers and payers?
That is an excellent question. And that is why I think if we go back to the chart here, I think what's really critical are these links to quality and value, and that there are quality contracts for those providers, quality contracts which include outcomes for the population that they're serving, because we certainly do not want there to be incentives in the system to withhold care, and instead we want the incentives to be properly calibrated to provide appropriate care in the right setting when people need that care, and care that is going to contribute to improved outcomes or improved status for a condition. So the quality and performance metrics that are key in all of these are really key in all of these contracts. And that's a place where you might want to dig more deeply with, for example, our Medicaid program. You may want to explore that with OneCare Vermont as well in terms of the way they contract with other payers. But it is something that is evaluated to see that there are alignment between quality and performance measures to the degree that it is reasonable between the different payer contracts, and that alignment serves to strengthen the focus on those particular quality metrics. But those are very much a part of these value-based contracts, which are not just providing for incentives. Again, they're not providing incentives to withhold care. Instead, they are providing incentives to offer the most appropriate care in the most appropriate setting for the best possible outcome.
Thank you.
Thanks, Ina. I think we can move on.
Okay. And I am very excited to be with you in person tomorrow. I certainly,
Yes.
I find the online testimony is tricky. So thank you for bearing with me.
Yeah.
So now I'm going to talk about the Vermont All-Payer Accountable Care Organization Model Agreement. And so we've been talking at already different levels of agreements between payers and providers. The All-Payer ACO Model Agreement is it's a state contract. This is a contract between the state of Vermont and the federal government and the Center for Medicare and Medicaid Innovation specifically. We often refer to the Center for Innovation by its acronym, which is CMMI. And the Innovation Center was created by the Affordable Care Act and was provided with the flexibility specifically to test different payment models for Medicare. To test the hypothesis that by changing reimbursement models that there can be improved healthcare quality, improved experience of care, and moderation of healthcare cost growth. And the Innovation Center has been working to test alternative payment models and to provide states with funding and investment for these alternative payment models for quite some time. In fact, I'm going to go back to this chart for just a minute to talk about Vermont's history with alternative payment models and how we also have interfaced with the Innovation Center through state innovation model funding. So the Blueprint for Health program, which I know you're going to get a deep dive into later this week, is an all-payer program launched in Vermont in 2008 and is still active today. And this program, again, provides for enhanced payments and for payments that support community health teams that work with patient-centered medical homes and offer connections and bridges to community-based care. These teams also support those primary care providers that choose to offer medication-assisted treatment as a part of the hub and spoke model. And there are additional investments for that model, as well as providing support for those practices that offer the Women's Health Initiative, which we are referring to as WHI, which offers screening and support and long-acting reversible contraception for individuals in a same-day visit if that is what they choose. Oops. And so the Blueprint model, again, has been in place and working for quite some time and really serves as the foundation for our work that is seeking to shift more accountability to healthcare providers, along with predictability for healthcare providers in terms of fixed prospective payments, which can be thought of as more akin to a budget or a global budget or global payment for healthcare services. From 2014 to 2016, using funds that we received from the State Innovation Model Grant, in part, the state developed aligned standards for multi-payer shared savings programs. So these ACO shared savings programs were operated prior to the Vermont all-payer model, and part of how we supported the development of standards for the shared savings programs that would be aligned across payer types was through State Innovation Model grants. And now we'll go back to the payer model agreement. So again, this is a contract that is between the state of Vermont and the federal government. This contract enables Medicare specifically to join with Medicaid and commercial payers in an aligned model to pay ACOs in Vermont differently than fee-for-service. When we talk about what an aligned model means, we are talking about those services for which providers have accountability. Now, one thing that was mentioned was talking about a prescription. In this model, there isn't currently included in the model accountability for the cost of prescription medications, and that's for a variety of reasons. But one of those really critical reasons is that through the Medicare Part D drug benefit, it is very difficult to track and capture total spending for prescription drugs. So prescription drugs are not included in that bundle or bucket of services for which providers do have accountability in this model. Providers do have accountability for services that we would term relative hospital and physician services, but that's a bit misleading because it's really services that Medicare will pay for with the exception of prescription drug, and Medicare does include coverage for mental health and substance use disorder services, for example. Quality measures, as I indicated, are also aligned to the degree that is possible across the different payer programs, so that there can be continuity, focus, and increased incentives for work in those quality measures. And also, this is a key place where administrative burden for providers can be addressed to a degree, whereas if every single payer type is saying we want to have a value-based contract with providers and we're all interested in very different quality measures, then that can be overwhelming, and that can dilute the focus where there needs to be key improvement. So it's been important that quality measures are also aligned. Payment mechanisms and risk arrangements are also aligned in this model. And again, I wanted to highlight that this model is intended as a cost growth moderation and quality improvement initiative. It's not a coverage expansion model. It's not an insurance marketplace improvement model or initiative, for example. There are 3 signatories on the all-payer model agreement. Signatories include the governor, the Agency of Human Services secretary, and the chair of the Green Mountain Care Board. The agreement was originally executed in October of 2016, and the first year of the contract was 2017, and it was a performance year 0. This agreement and the work that led up to the agreement, again, was very much informed by Vermont's long history and development of supports and foundation of support for primary and community-based care providers that could be supported in focusing more on prevention and whole person care. The agreement was also informed by Vermont's experience participating in that shared savings program where providers were only at risk for upside shared savings. It was an upside only shared savings program. And there was consistent feedback that with upside only shared savings program, the incentives were not strong enough to promote differences in how care would be delivered, efficiencies in the system, and ultimately to contribute to healthcare cost growth moderation.
I'm going to stop you there for 1 second. We have a question, Art.
Yes,
Yeah.
please.
Rob Peterson here. Ina, is there a fee or cost difference to the patient comparing risk to value-based payment? And you may have answered this already. I just wondered, how does this affect the cost of the patient? All talked about today.
That's a really good question. When we were working on this agreement initially, we had some really important principles that and some of them were related to Medicare and Medicare beneficiaries' experience in particular. But certainly one of the key components of this agreement is that the agreement, even though there are contracts between the payers, that includes Medicare as a payer, Medicaid, as I indicated, and then commercial payers, those contracts between those payers and the ACO would have, and the ACO is a group of providers that are voluntarily coming together to be accountable for the cost and the quality of care for a population. But that doesn't mean that that's a closed network of providers for Vermonters. Vermonters continue to have, whether it's through their Medicaid, Medicare, or commercial coverage, the exact same access to the same providers that they always had, with no change whatsoever due to this model, to the benefits that they're entitled to through the terms of their health care coverage. So this is, to put it bluntly, more of a back-end payment model versus a change to the coverage for an individual or a change to the model of available providers. So that's one thing that's really critical. And further, critical considerations were certainly that, yes, there could be, for individuals who have cost sharing components, if there are, for example, through the model, it's identified that you need some earlier prevention or more regular preventive visits in order to promote your health and wellness in the long term, then those preventive visits would still have the same costs associated with them, depending on whatever your plan is. So there would be no change there either. Does that help to answer your question?
A little bit. I was more thinking that, I go in for some sort of surgery that's under a fee for service. And is that cost the same? Say it was $5,000 surgery. Is it more or less than that if that doctor was involved with one of the categories of value-based coverage? Is it like $6,000 because it includes some of those other values somehow? I'm just trying to get my head around what the difference is.
For you as a patient, there's no difference. There's no difference. If for you as a patient over time, if there is success in curbing healthcare cost growth or moderating healthcare cost growth, then over time, there could be something, that impacts, your total costs. But that is like over time. That means a long time horizon for like bending the cost curve and moderating the rate of growth. And it's different in terms, and what we mean by that is that healthcare costs, which we know grow faster than other parts of the economy, that healthcare costs growth would moderate over time based on implementing models like this.
Okay, thank you.
So we have Joe, and then we have Topper, and then we have Bobby.
My question is one that it's a wrap-up question, but I want to get in before the evacuation drill because perhaps it's something that's better talked about tomorrow, so you can defer on this question. I was talking to a colleague earlier today. What's going on in your committee? Oh, we're talking about ACO. That's a disaster. And I guess my question is, and again, perhaps this is better for tomorrow, and I didn't have a response because I'm still trying to understand what it is. Why is there a perception in the public that this is a disaster? And I'm not trying to put any sort of value on that because I don't know enough at this point to say whether it's a disaster or not. But there certainly is, I feel like when I talk to people about this, their initial reaction is this is bad, this is not working, this is not accomplishing whatever it is we want to be accomplishing here. So I wanted to throw that question out there for either consideration now or consideration later, whenever it would be most appropriate. How do you respond to the critics, I guess, is the question I ultimately have.
So that is a very good question. And there are a lot of different perceptions and feelings in the healthcare system and in the public about what we're doing. I'm going to ask us to hold that question for whether tomorrow or we will eventually have the ACO in, and that would be a very good question to ask them as well. And then I think when we start looking at the quality metrics that Ina discussed earlier through the various entities, that's also kind of a good back of the mind question to have as we look at that. So that's okay. I'm not going to have Ina address it right now. Topper, unless you want to, Ina. All right, Topper.
Thanks, Madam Chair. I look at the savings that are listed here. I'm just wondering, in terms of the administrative end of the budget, what kind of savings were there? Or were there any?
And I think you're probably looking ahead to the savings that were for the Medicare program specifically in the evaluation. I think that's probably what you're looking at. So I think, and when you're talking about those savings relative to the operating budget for the ACO might be what you're thinking about.
Hold on, Ina.
No, I'm looking at savings of 64 million under the Blueprint for Health and there's savings listed under the all-payer model.
In the chart that had the boxes with the squares around it?
Yes, yes. So those savings are savings that the Medicare program has identified as being relative to these specific models. So the Medicare program has, when it's testing alternative payment models, it certainly has a strong interest in determining whether what it's testing is scalable or should be employed more broadly across the United States, and whether it's yielding savings. So those figures there are for Medicare savings for Medicare due to Vermont's work in the Blueprint for Health. Vermont used to be a part of a Medicare demonstration that was called the Medicare Advanced Primary Care Practice Demonstration. And that was focused on improving primary care through these enhanced and alternative payment models, and then was evaluated for its effectiveness. Vermont was the only state among a cohort of states that showed savings for the Medicare program in this primary care focused delivery model. Vermont was also I believe the only state that invested in community health teams to support the patient-centered medical homes. Those are the high-performing primary care practices, which may have differentiated Vermont quite a bit from the cohort of other states that were working on strengthening primary care. Then Medicare also evaluates the all-payer model because, again, Medicare is trying to test different ways to pay for healthcare, whether or not those different ways to pay for healthcare coupled with expectations and goals for delivering care differently yield results. And Medicare looks at how the all-payer model generates savings for it. There is an independent evaluation that the Center for Medicare and Medicaid Innovation contracts for. So it doesn't evaluate its own models. Instead, it contracts with an independent evaluator to look at how the models are performing. And in the years that it has evaluated the model thus far, it has focused on Medicare only and the savings for the Medicare program only. In future years, it will incorporate Medicaid and commercial into its evaluation, but that has not yet happened.
Bobby?
Well, hi, Ina, and everyone. I hope you can hear me. I'm trying very hard to wrap my head around this, and I have COVID right now, which is probably adding to the difficulty. But I keep thinking of an analogy that might help me explain this to people who haven't had the chance to sit in on these meetings. And I kept coming up with the idea of something like Netflix. I know this sounds crazy, but the fee-for-service model, which we've had in the past, would be kind of like if everybody had to pay for each show that they watched on Netflix, versus right now, everybody pays a flat fee. And some people might watch one show a week. Some people might sit there with 22 hours of content streaming constantly on their TV. And Netflix has to pay for the servers and the internet connections and all that to make that happen. But they balance it out by figuring out a price that everybody can afford. And hopefully, as this is a for-profit company, so it's not a perfect analogy, but they make a little bit of profit because of the fact that not everybody is fully utilizing every possible service that Netflix provides. I don't know if that's a good analogy. And the other one I thought of was like of a life insurance company, which is a little close to health insurance, but it's kind of the idea that everybody pays a premium. Most of us are fortunately not going to have a tragic and premature death. So the life insurance company collects premiums and only has to make a payment on the unfortunate but unusual circumstance that someone dies prematurely. I mean, would either one of these analogies be useful to comparing the fee-for-service versus the all-payer model?
My initial reaction is yes. I am definitely an introverted sort of personality, and I need time to process information and think it through and reflect on it and then determine, okay, is my initial reaction right or wrong? But if that feels right to me. And I know that there's been another analogy that's been used quite a lot in this space, which is the difference between paying a contractor time and materials versus paying, a contractor makes a bid for the total project and it sticks to that bid. That's been another analogy that's been used a lot to help people think about what we're talking about when we're talking about paying or reimbursing differently than just the fee for service, which would be more like time and materials versus the the bid for the total project. I think I like Netflix better though. It feels more topical. It feels more fun. I like to binge watch shows. So.
All right. I think it depends on the audience. That contractor one would work well with some folks and the Netflix one would work well with other folks. I think it depends on who I'm trying to explain to. But thank you for that. That's useful for me.
Thank you for that. I'm going to use it too.
All right. I think we're good if you want to keep going, Ina.
Okay, so the agreement was originally executed in October of 2016, again, and it really reflected some of our key learnings from participating in an upside-only risk program where there were still fee-for-service payments happening, and providers were also not at risk for the total cost of care. This agreement has been extended for, I'll show you the timeline here. So you can see the original agreement term included a year 0 in 2017, and then 5 performance years, 2018 through 2022. So the 5th performance year has just concluded, and we have negotiated and executed an extension of this agreement for year 2023 or performance year 6. And the state has an option for an additional extension year in 2024. And we will talk more about this tomorrow as we talk about where we are very much partners with the folks in the federal government who are looking for how Medicare can work differently in states and are certainly looking to provide states with flexibility for Medicare to be tailored and to align with state goals and preferences for healthcare reform. And as we work in partnership with the Center for Medicare and Medicaid Innovation and look towards a future potential model, we're also mindful of the timeline that they're working on for a potential future model. And it may be that another model is not available to begin in 2024. And that is why they wanted to ensure that we had the option for an additional extension year.
And Ina, if I can just add on this slide, and apologize if you were going to say it, but let's keep in mind a couple things. One, healthcare data to evaluate what is working and isn't working has a very long lag time. So, people will say, well, we've been in this for 5 years and it's not showing if it's working or not. We have to remember the last set of data we really have is from 2019, right? Because then we hit COVID and we had the pandemic. And so, 2020, starting in March of 2020, 21, and most of 22, things have just been very different in the healthcare system. We had a big dive in who was going to doctors. We've had an uptick now. We've had acuity uptick. So it's performance year 3, 4, and 5. I mean, we wouldn't even have year 5 data yet. But any data we're going to get for those 3 years are not I don't know how to say it. I mean, it's not normal data, and who knows what's normal going forward now, which I'm sure is part of the discussions that we're having with the federal government. So, Ina, I don't know if you want to add anything to that.
That's a really astute observation. Not only did data lag prior to the pandemic for us to be able to understand what happened in a year where the model was in place, where providers were paid differently, where there were efforts to support providers in learning different delivery models, using tools like Choosing Wisely that could support decision making about the most appropriate care for an individual. For example, sort of clinical best practices, evaluating data, looking at trends, looking at overall, population health. All of those activities are kind of what's happening within a year in this model. And then from after that year closes, like 2022 just did, then there's a great deal of time necessary to be able to look at all of the different data types that would allow us to assess what happened in that year. That includes claims data, clinical data, sometimes patient survey data, and to, make sure all of that data is making sense, sorting it through with healthcare claims. That's the data where the provider submits a bill and the bill is paid. Those can lag, many months because of the claims process, because of there being, open claims. So in an ordinary world, there would all be a delay there. And certainly we do have an evaluation report from Medicare for performance year 3, 2020. And that report details some of the additional delays in time and assessment that came about because of what the system, how the system has been so significantly disrupted by COVID-19.
Great, thanks, Ina.
And I think that's another point that is important to emphasize, that the model is intended to support providers in transforming care delivery and providing for, and that work is intensive work, it's on the ground work, and it's work that's at the real site of care. And as you can imagine, in 2020, for example, with COVID-19 presenting so many disruptions to the system, where there were so many unknowns initially about how to handle the novel virus, that work on, typical process and quality improvement activities really became redirected to deal with this unprecedented pandemic. And I think that's really also critical to talk about. And there have been and continue to be ongoing impacts from that disruption. And I'm sure that you're going to be hearing about those as you continue to do your work.
So we have a couple questions, but I'm also mindful of the time. So my question to you is, to ensure we have the background we need for tomorrow's discussion, I'm going to hold questions for just a couple minutes and let you focus on what you think we need to know for tomorrow, or if you think we'll have time to move some of this presentation in tomorrow. So I'm going to leave that into your hands. And then Art and Leslie, if you can just write your questions down. And
I have to comment.
Okay. Okay.
I mean, I'll just talk to the topic because I wanted to comment.
Okay. So Ina, back to you.
Okay. And I'm happy to be flexible in how you want to work with the time we have available tomorrow. I know we have a couple of topics on workforce as well as the future potential multi-payer model. So this.
Are you there, Ina? Did you?
Hi. Can you still see me? I'm sorry.
Yep. No, we're good. You're good.
I was having a slide advancing issue, but I think I've moved ahead now.
Yes, we can see it.
So we've talked a lot about this all-payer ACO model, and probably I should have ordered these slides a little bit differently, because I think it's really important to define what accountable care organizations are. Accountable care organizations are, it is something that was created and supported by the federal government in part through the Affordable Care Act. Accountable care organizations are when healthcare providers come together to be accountable for the cost and quality of care for a defined population. And in coming together, there are some particular protections that the accountable care organization structure provides so that the providers can, like, for instance, coordinate care and share in savings and work together in ways that they otherwise may not be able to do so because of antitrust considerations in particular. So the accountable care organization provides a legal structure for sharing, working together, and in particular, sharing savings. And accountable care organizations also, can be made up of those providers that are interested in working together and certainly invested in coordinating care across the population. And you will hear more about this when you have other discussions with other experts in this area. But the One Care Vermont, which is the ACO in Vermont that is participating in the all-payer model. One Care Vermont has a very extensive network of providers that are participating in the accountable care arrangement, and that network spans from nearly all of the hospitals in the state, with one exception, on through a whole range of community-based service providers, home health providers, skilled nursing facilities, mental health providers, specialists, and specialty providers. So it has a very broad network of providers that participate in it across the state of Vermont. And so we really do have a statewide, the ACO's network is a statewide network, which does make it really unique among ACOs in the United States. Oftentimes ACOs are based, in a smaller region and may have fewer provider types that are coming together to coordinate and participate in accountability for patient care. So we also talked some about how this agreement works. There's first an agreement between the federal government and Vermont, and this provides an overall framework for all payer reform and specifically provides for Medicare to pay differently than fee for service in the state. And the only mechanism for Medicare to pay differently than fee for service is through an arrangement in this agreement with an accountable care organization. And then accountable care organizations that participate in the agreement, they and the payers, Medicaid, commercial, and Medicare, they develop ACO level agreements for what this group of providers is responsible for relative to a defined population. And then the ACOs and providers that want to participate, they work together and they develop ACO and provider level agreements. And we were talking about that a little bit before. There are some ACO agreements with a hospital. Those are different from whatever the hospital's contracts are and agreements with its employees, for example. But the hypothesis is as much as those hospitals' contracts with its providers can align with the contract that it has for an alternative payment model with the ACO, that is going to strengthen the overall incentives.
So unfortunately,
oh no, is your fire drill? Oh no.
No, not yet. So Daisy, is your question quick?
It's a quick comment. And you just said something that I don't want to get lost. First of all, I want to say I know very, very little about ACOs, but I do want to say this. I wish you had put this slide sooner, because Ina and I have talked in the past about this before, about how I wish there were educational materials circulating in the public about what the ACO is, because it's not as complicated as I think it is often made out to be. And and correct me, Ina, if I'm wrong, but the ACO simply is in essence, bearing the financial risk of delivering care in Vermont. At its simplest, Ina, is that true?
The participants in, yes, the ACO, yes, is bearing financial risk. It is made up of providers that have financial risk for the cost and quality of care.
And you made a point that I wanted to lift up about the participants and how unique Vermont's ACO is in that we have so many. And I know that's true. And I think this ACO, Joe made a point earlier about it, you know, something about the stability of it. And I think because we have such an array of organizations that participate, it's important to just sort of look at that as one of the measures of the ACO is the diversity of participants and the number of participants and the stability that that brings to our system as a whole, not to mention to each individual provider and their own financial stability. So I just wanted to recognize that point.
So with that, Ina, I think what I'm going to say is I'll connect with you later and figure out how we're going to arrange tomorrow. And we will take a break here for everyone, just 3-4 minutes, and come back and we'll start the session with Nolan and Amron. But Ina, this obviously is really important for us to understand. So I appreciate the time we have put into it. And we'll, like I said, I'll connect with you later.
That sounds good.
Great. Thank you so much, Ina.
Thanks, Ina.
Thank you, Ina.